Good afternoon, everyone, and welcome to the University of Alberta Division of Gastroenterology, IBD TV. I'm Dr. Richard Fedorik, and we have an exciting program for you today on pediatric IBD, dealing with all of the special needs that our young patients with IBD have. We've got a great crowd for you today. I want to introduce Dr. Etan Wine, a pediatric gastroenterologist from the University of Alberta. Dr. Matt Carroll, pediatric gastroenterologist also from the University of Alberta. And in the center between those two lovely gentlemen is Dr. Karen Croker, who you know from our past shows is one of the adult gastroenterologists from the University of Alberta. This program is brought to you by an unrestricted educational grant from AbbVie Canada. So we might as well get started on today's program. Dr. Wine, welcome to our program, and looking forward to what you have to tell us about pediatric IBD.
Thank you very much, Dr. Fedorik. It's a pleasure being here, and I am personally looking forward to the opportunity to hear what the families and the patients are interested in. But I will start with a very broad introduction on what pediatric IBD is, and really focusing in a few minutes on some of the questions that I think might interest everyone. And over the next few minutes, what we will be talking about is, first of all, the question that we hear in many cases: do kids really get IBD? And the answer, of course, is yes, otherwise we wouldn't be sitting here. In what way is IBD different in children? And I think that probably relates to many different aspects. We'll focus on a few of those. How do we diagnose and treat children with IBD different from adults? And what are some of the special considerations that we have in children with IBD and adolescents relative to adults with IBD? So regarding the first issue that I raised, does IBD happen in children? The answer is absolutely. In fact, the peak of the disease seems to be within the first 3 decades of life. And as you can see in front of you on the screen, the peak is mainly between the age of 12 to 25 or 30. Therefore, we see a relatively large portion of the presentation within kids. And in fact, 25% of those diagnosed with IBD do present in childhood in most places in the world. Our interest, of course, is Canada. And in Canada, we have always been documenting the frequency of disease. And we found that, in fact, over the last couple of decades, there has been a quite dramatic increase in the prevalence of disease. And if you look at the graph in front of you, the top line shows the accumulation of disease every year. And you can see that for IBD all over and for Crohn's and ulcerative colitis, at least from the study in Ontario, there certainly has been an increase showing that it's becoming more prevalent. But, we're not going to discuss all of the details about IBD, but just for those who need a bit of a reminder or a bit more background, I will remind you that the two most common presentations of IBD are Crohn's disease and ulcerative colitis. And what you can see in front of you on the screen is, on the left, the healthy individual with endoscopy on the top, and what the biopsies look like. We call it histology on the bottom. In the middle, you'll see Crohn's disease individual, where you have these long white patches, which are ulcers actually, and they seem to be quite deep and dramatic in this individual over here, which is very typical for a case of Crohn's disease. On the bottom is some of the typical findings that we might find in a case of Crohn's disease, with what we call granulomas and other changes. And I think that for many of you, it's just quite obvious that it's very different from what you see on the left. And finally, on the right, ulcerative colitis has a much more diffuse presentation seen by endoscopy and destruction of the normal structures as we see them on the biopsies below. The most typical presentations of patients with IBD are listed on this slide over here, and they will usually involve abdominal pain and diarrhea, which we hear in most cases. Urgency and painful bowel movements at night are also quite common. And some cases we will hear a description of a sore bottom with pain around the bottom. Other presentations that certainly can happen in adults as well are fatigue and weight loss and poor appetite. And other presentations are also a possibility. But focusing on children, there certainly are certain aspects that we pay more attention to and differ from what we see in adults. We pay a lot of attention to growth, development, and puberty, which can all be very much affected in children with IBD. And we also really focus on the very young patients with IBD who might have a bit of a different type of presentation, and we might discuss that in a bit more detail later on. One of the findings that is quite consistent across the world and is very interesting is that those that present in childhood overall appear to have more extensive and severe disease, even though, of course, we still have the range from mild to moderate and severe in children as well. When we look at diagnosing and treating children with IBD, a lot of it is very similar to what's been discussed with adults, but there certainly are some specific factors that we take into account. So, of course, a diagnosis is based on a whole bunch of different factors. There is not one single test that makes the diagnosis. And we look together at the history, the story that we hear, the findings on the physical examination, radiology, and endoscopy. We also pay a lot of attention to the growth, as I mentioned earlier on. We do try to perform MRI as opposed to CT or a contrast study called follow-through that has been done in many cases in the past in children. And then a lot of our endoscopies, most of the endoscopies in children are done under general anesthesia, just because, of course, this is a different population with different considerations. And in adults, that's not always the case. Treatment considerations, so a lot of the tools we use are very similar to those used in adults, but I've highlighted some of the different factors. For example, nutritional therapy is a different modality that is almost completely unique to children. And if there are any questions about that, we'll be happy to provide more information. We try to reduce the exposure to steroids, as do our adult colleagues, but I think in the case of children, the effects on growth are quite profound, so we do what we can to reduce that when possible. And then other considerations are the fact that a lot of drugs are first tested and developed in adults and therefore not always available at the same time in children, which can be a limitation, but in some cases it means that we're doing less experiments on your children, which is an important point as well. And the last slide, some points for discussion about challenges for children with IBD. Of course, very young children, it's difficult to understand their symptoms and we're not always using the same words, so getting the information from them can be a challenge. And on the other hand, older children, and of course there's a lot of variability with this, we don't always hear all of the details. The body image issues associated with having IBD in adolescents are quite significant, and we pay a lot of attention to that. Like any other chronic disease, there's a lot of challenge in dealing with all those conditions, and we have to remember that treatment in IBD in many cases is long-term, so we have to balance the long-term effect of disease versus a long-term effect of side effects of drugs. And then, of course, dealing with school, friends, family, and finally, we recognize that we're not only treating the patient, we really are treating the family as a whole. So with that, I'll end this brief introduction and happy to take any questions and points for discussion.
Thank you, Dr. Wine. That was a wonderful review and some of those very important points, and I'm going to get those points put back up on the screen in a moment. I just want to remind the audience that this is your time now to type in your questions. You've got 3 gastroenterologists here, 2 pediatric, 1 adult, who are willing to take your questions, answer whatever questions you might have about Crohn's disease, ulcerative colitis, pediatric, and we'll take some adult questions today as well. So while people are writing in their questions, let me just ask you, Ethan, thinking back to my own kids when they were younger, they often had stomach aches. They complained a little bit of a stomach ache. And as a parent, you're always nervous. Am I missing something? Should I do something? What advice could you give to parents for them to think that their child might have something more serious than just a 1 or 2 day stomach ache? Are there any tricks that you have?
That certainly is a question that comes out quite a bit. And I think that defining normal is really one of the key issues that we have to address here. So there's a wide range of normal. We know that as any individual, we can, feel some pressure in our arm every now and then, or different feelings within our body. And how do we differentiate that from a more significant disease? And I think that everyone has their own threshold for pain. We recognize that. I will say that in most cases, IBD is not just one symptom. We will have a combination of different things happening, and we keep that in mind. And one of the challenges that we have and the goals that we have when we see a child in clinic is to really try and differentiate between a normal happening and something a bit more severe. And we will need usually several different measures to make that decision. So it's not there is not one single test that can be done to diagnose this disease, as I mentioned earlier, and there isn't one single symptom that I can say that will always be a representative of this condition.
Mm. So it's a combination. You look
Absolutely.
for that combination of things and the longevity of it.
Absolutely, and there is a range. So, you know, some patients will not have any pain at all, and they'll just have growth problems and abnormalities in blood work, whereas others may have only pain, but in many cases, there will be something else that will be hinting.
Right.
So all of those listening to us now and concerned about their child complaining about pain a couple days ago, IBD is a bit more serious than just that alone.
Right. And so there's questions coming up for pediatric questions, but there is a question that I want to address to Dr. Croker, and that is, this would apply to both adults and pediatrics, obviously, but the question is, do I have to take medications for life? Dr. Croker, how do you answer that when I ask you that question in this disease?
So I usually start by saying that IBD is a chronic condition, and so when it's a chronic condition, in order for you to stay well, I say yes, you do have to take medications for life, but which medications you take for life may change because we know that we're actually doing more and more research and we learn more and more about the disease. So when Dr. Fedorik was a young doctor, he used different medicines than we use now, and so it actually is exciting because we know that there's differences in that. We know that you need to get you better with medicines or surgery and then keep you better. And the medications we use, that's the purpose of it. And so as much as people don't like to take medications, the benefit of taking them is usually outweighs the benefit of the risk of not taking them, because you'll just get sick. So yeah, in a word, yes, you have to take medications for life.
A word, yes. And you're implying that I'm an old doctor. I think that's
well,
that
you said
phrase.
there's only 3 doctors willing to take questions, and so I was not sure who wasn't willing to take questions today.
Okay, good point. So let's go to Dr. Carroll, and we'll ask one of the questions. My child has a problem, so I'll read the question out so everyone can hear it. My child has a problem with growth, so I assume that child is not as tall or as big as the parents think he or she should be. However, my laboratory tests are normal, yet we have a family history of IBD. Should I take my kid for further investigation? So, Matt, Dr. Carroll, how would you answer that question for the parent?
Thank you, Richard. Look, I think it's an excellent question, actually, because we not infrequently get situations very similar to this. And for the most part, we have to sort of take a step back and say, okay, well, what specifically is the problem with growth? And when we're talking about growth, we're not just talking about a single point in time for children. One of childhood's main priorities, I suppose, is to make sure that the child grows. So putting on weight, gaining height, that's something that occurs over a long period of time and has periods of both rapid and slower activity. So we tend to try and look at what the history of growth has been over time. And this comes from a variety of sources, but clearly, what the family have been observing at home and what the family doctors have been observing does give us some information from that point of view. So when growth is then investigated, it can be a problem for a variety of reasons. And we don't really have the scope to go into what those reasons are, but certainly, as we've heard from Dr. Wine, having inflammatory bowel disease may indeed be one of the reasons why growth can be affected. So then we look for these other markers, if you like. So are there other red flags that may tip us off to this being inflammatory bowel disease as opposed to another potential reason, and not necessarily a gastrointestinal reason for poor growth? And so the instance we've got here that the laboratory work, so the blood work performed was normal. And the sorts of things we look for there are, now, is there evidence of anemia or a low blood count? Is there evidence of inflammation? And again, these aren't specific to inflammatory bowel disease, but we do very frequently see them associated. And then the critical issue here, I suppose, is the family history of inflammatory bowel disease. So this really increases that index of suspicion. And I think for family members who aren't really sure, should I be worried, should I not be worried, the advice here is go and ask. Go and ask your family doctor, go and ask your paediatrician. And in a lot of instances, we do get problems, we do get referrals, I should say, to our clinics as the gastroenterology clinic in paediatrics, where paediatricians have done a pretty thorough workup. And we do have a problem where blood work's normal, growth's not such a great thing. And in some instances, we just have to ask that question, say, well, there is a family history. This potentially could be inflammatory bowel disease. And if that's the case, then we do further investigations. And that's where we would start to look within the body, look at the lining of the bowel using the endoscopy techniques, where we have the camera through the bowel, and try and find some more definitive evidence. In other instances, if there appears not to be such a red flag, or we can get more of an idea that growth is maybe explained by, or poor growth explained by some other mechanism, then it may be reasonable to monitor that. I think the point there for families at home and for parents who are worried, in that particular situation too, where there is an association with inflammatory bowel disease, we should be looking and asking that question.
Great. And you talked about family history being important. Does it matter whether it's the parents that have IBD or a second cousin that has IBD? Is there any, would one make you look more carefully than the other?
Most definitely. I mean, the more direct the family history, the greater the likelihood of having disease within that child or a sibling as well. It may not necessarily be a family history within the parents or the extended family, but if there's a sibling who has disease, then other siblings we should have a much lower threshold for considering such a diagnosis. The further you go out in a family, great aunt Bethel was second cousin, twice removed, it gets a bit tenuous, and really it is more of a direct family history that tends to convey that risk to the individual.
And I want to pick up on another thing you mentioned. You mentioned the endoscopy, actually looking into someone's intestine, and we've talked about endoscopy on earlier programs. Parents and the kids are going to be frightened about the medication, the sedation. So, and I think, Dr. Wine, you mentioned general anesthetic. So, Matt, do you want to just talk a little bit about how we sedate the kids and what we use?
So, I mean, I agree. I think for anybody, child or otherwise, having a procedure you have to come in a hospital and have these sorts of things done can be very frightening. And so in this instance, what we try to explain is that first and foremost, the child's going to be asleep. They're not going to be able to feel anything, they're not going to remember anything, and they're not going to have any pain associated with the procedure. And that's a really big thing. So, I mean, up front, that's one of the things that happens, and that's essentially true, I think, for anyone doing an endoscopic procedure. That's our goal. There are some certain differences between the way in which an endoscopy may be performed if, Uncle Bob had one or, an adult's had one versus when a child has one. And particularly what we do is we do this as a formal anaesthetic procedure. So we have a paediatric anaesthetist who is there to administer essentially a general anaesthetic. Now, that doesn't necessarily mean that the child is paralysed and has to have a breathing machine or anything along those lines, but they are deeply asleep. Mm-hmm. And so people often are familiar with endoscopy procedures in adults where that may be, people refer to conscious sedation or twilight sedation, and they're maybe a little bit awake, but they don't remember things. The kids are completely asleep.
So you try and take away all the fear that the child may have about that.
Because kids can be a little bit tricky with some of these things, and often they aren't able to tell us what they're experiencing.
Right.
And certainly anxiety can also impact on how people respond to an anaesthetic. So we have a paediatric anaesthetist there whose sole responsibility is to look after the child's anaesthetic, putting them off to sleep, waking them up, and ensuring that all goes smoothly.
Excellent.
So that's a very distinct difference. And sometimes as a result of that too, we may have a different environment that we do the endoscopic procedures in. So sometimes our procedures will be done within the paediatric operating room, even though it's not an operation per se.
Right. Everything to be safe and
absolutely. We're just taking the safety precautions, making sure all the monitoring is available.
So the parents should rest assured that the child will be comfortable during the procedure.
Absolutely.
Yeah. Let me ask a couple of other questions here. There's one, maybe this one Dr. Wine might want to address. And again, I'll read it for the audience. My doctor put me on nutritional therapy. So I want you to explain what nutritional therapy is.
I was expecting that question.
Is that Coke and pretzels, or what is that? and for Crohn's disease. So the question is, how long do I have to be on this nutritional therapy? And do I have to take medication after that? So why don't you try and tackle the nutritional therapy?
Absolutely. So we see the availability of nutritional therapy as a huge advantage, and I'll start out by saying that the reason that it's not used as much in adults is, first of all, the studies have been mainly done in children, and the positive results that we do have do suggest that it's effective in children. Those studies done in adults have not been as effective. And the other point is that for some reason, and I think that I've gotten to know kids quite well, kids are much better at doing this because it's not an easy treatment. Essentially what it means is that instead of eating your normal diet of 3 meals a day, what you are doing is drinking these shakes, and we try to present them in a positive way because really they are food that's broken up. And I'll explain. Well, you know that so
Special milkshakes.
Not true milkshakes.
Exactly. and we use different brands, and there are different brands available throughout the world, but essentially they are very much broken up food and a very controlled nutrition. And the way we think this works is twofold. First of all, by avoiding what may be potentially injurious components within food is one aspect. And if we remove all of, we call them antigens that might stimulate the immune response from the food, then the immune system might quiet down considerably.
So I'm just going to stop there. So these are liquid drinks you have to have.
Yeah.
And it's like pre-digested food, so your body doesn't have to digest anything. Is that what you're...
Essentially, yes.
How do they taste?
So, you know,
yummy, I bet.
Taste is a very individual thing, and that's the point that I referred to earlier. Kids seem to be, of course, you know, everyone thinks their kid is a picky eater, and I know that mine are. But the point is that taste really is...
Still a picky eater. So.
The point is that taste really does vary from person to person. And one of the things that is most challenging is the fact that what you're drinking / eating every day, a few times a day, tastes pretty much the same. So we have come up together with our dietitian with quite effective ways of making the taste a bit more appealing and adding a bit of a variety with different tastes. But we have vanilla and chocolate taste nutritional therapy that we can offer, and they are quite sweet and palatable, and you know, kids do enjoy them during the first few days usually, but it does become a bit of a challenge when you're taking that for a long time.
Well, the question is, how long do we have to take them?
We usually tell our patients that they'll be taking them for 6 to 8 weeks during the induction phase, and the word induction is exactly the word that we use.
And what do you have them do at school? So do they take the little drinks to school?
So there are different options. Most children at school age will take a lunch with them to school, and if you can keep it in a fridge or in a cooler and then take it out during lunchtime, that will be your lunch meal. And you know,
could you swap and give somebody else your drink and then eat the sandwich?
I can't imagine that's ever happened, Dr.
No, I wouldn't think that would happen. No.
Probably a very hard sell.
Yeah. Anyway, but I do have to say that there are many different options. We do have some children that have a lot of difficulty drinking this nutritional therapy, so they actually will prefer to have a small tube put down their nose into their stomach, and then they can get the food overnight while they're asleep. Other kids have no problem just taking can after can. And it is very variable. But then the other component of the question is, once you're done with that, what's next? And I think that relates to what Dr. Croker was discussing about, does IBD really require long-term therapy? The answer is generally yes. There are very rare occasions where reluctantly we agree to see what happens without therapy. But I think we know from our experience and from experience across the world that even if we are able to induce remission with nutritional therapy, the likelihood of the disease coming back still remains significant when we stop it. So it always is our stage A of making the patient better, but it almost always has to be followed by what we call a maintenance therapy that will keep you well over time. And I have to say that there are some centers where nutritional therapy has been used for maintenance, and that will not mean that you're not eating normal food at all. What it does mean is that you'll have half of your calories from the nutritional therapy. I have to say that we haven't been practicing that much. We don't think that it's easy to do, and we also have not been convinced that it's very effective. But for some of our patients, it has been a good solution.
So there are options for children other than medication that seem to work really quite well.
And that's the main attraction for this option, because other medications will all have side effects. This one is not easy to do, but really has zero side effects as far as comparing it to other medications. That's a huge advantage.
Let me ask you, you'd mentioned one of your slides, steroids, corticosteroids, which are used a fair amount in adults because they reduce inflammation a lot and can be quite effective in the short term. But you said you avoid them in children. Why is that?
We reduce the use and we try to avoid them, but in many cases we can't, since that really is one of the most effective tools that we have to treat both Crohn's and ulcerative colitis. And in many cases, immediately after the endoscopy, which you now know a bit more about, when we've made the diagnosis, we'll have a discussion with the family and discuss options. And I think having options is always a good thing. And the family may decide to, if and it really varies from patient to patient, but if we have an option of using steroids, prednisone as an induction treatment or nutritional therapy, that is a huge advantage because you can really select from those two options, and sometimes there are more options than that. But the reason that we try to avoid it is because there are a lot of side effects, and the side effects that we are mainly concerned about relate to growth, bone health, and these, there is an effect.
Steroids can stunt your growth.
They can, but if it makes your disease much better over a short time of a couple of months when we provide the steroids, that's a price we're willing to pay
to grow
in order to
later.
Get the disease under control and get them better. So it's more the long-term months and months of steroids that we really try to avoid, but we don't hesitate too much to recommend it for a few weeks or a couple of months.
So let's get to a couple of other questions here. My daughter was diagnosed at age 3, so that's relatively young for someone who have IBD, but it does happen. Responded well to treatment, has had no flares for the last 2.5 years. The question is, can children grow out of this disease and have it when they're very young and then not have it ever again? Dr. Carroll, do you want to take a stab at that?
Sure, happy to.
Do you have the magic answer?
Well, I don't know if I've got the magic answer, but I mean, as we define it, inflammatory bowel disease is a chronic condition, which means it lasts, it hangs around, you don't ever get cured from it per se. Having said that, we all have cases, and many people will know of patients or family members who have had inflammation of the bowel where it has settled down, has gone into remission, and then seems not to come back. Now, some of those patients as well, or some of those people may have come off medication and still have never had their disease come back. On the flip side of that, we know that there's a whole bunch of other people who do have their disease come back.
So that's an unusual for it not to come back.
It's an unusual, and I think, and whilst there's these odd cases, and they're the cases often that people want to hear about because it gives that sense of hope that this isn't going to affect my child for life. Unfortunately, it is a chronic condition, and it is something that we don't have a way of clearing from the body. Once you've got it, you've got it. However, the disease can be controlled, and it has periods of high activity where the disease may be very symptomatic, where there may be problems with diarrhea and tummy pain and things like that, and periods of time where the disease is what we call in remission, which is where, although the potential for the disease to flare up is there, it's actually under control and there's no active inflammation. And that's probably the period of time that people say, well, I'm cured. If they've had a long period of remission, which some people do have, they may think, I don't need my medications any longer. I'm cured of this, I've outgrown it. Where in actual fact, a lot of the research demonstrates quite clearly that for most people who come off their medication at that point in time have a very high rate of relapse, which is where the disease flares up, and that flare-up can often be much more aggressive and unfortunately much more difficult to rein in, even using the therapies that may have worked in the past.
So taking this advice to this mother for this young daughter, her young daughter would be, she's probably in a nice remission, that's great, but that likely the disease is there, will come back sometime in the future and to remain on your maintenance medication?
Absolutely. I mean, the potential is that the disease will flare up at some point in time, and hence why we monitor children long term and why we actively transition those our patients to the adult services so that they do have ongoing observation, even if they're well. It's very important that we keep on top of it.
Let's just ask another question here about surgery. I'll summarize the question. It says, and we had a whole session on surgery last month where we've talked about the different types of surgery with Dr. Kataru. The question here is, my child has Crohn's disease, can I expect them to have surgery? Is it going to be a must that they're going to have surgery in their future? Dr. Wine, how would you answer that for the parent?
I usually say it depends, because every individual is different.
That's definitive.
Absolutely. Well, I think the point is exactly that every patient is an individual, and their course we can try and predict, but we're not always very good at doing that. We certainly have to be prepared for the possibility of surgery. Surgery does happen quite often, although it is more often as a later complication that might appear after years or even many years of having active disease. And I think what we can certainly say about the last few years is that we're at least getting the impression, and we're starting to see evidence for that we are able to change the natural history of the disease, and we're able to at least delay, if not prevent, surgeries. So we're seeing less of them now than we have in the past. And I think in children that's especially true. So certainly, you know, the first 2 years when I was training to be a gastroenterologist, I was seeing more surgeries, and I'm seeing less of them now. And part of that is because the way we're treating our children, not only the tools that we have, but also the setup that we have, our understanding of the disease, our ability to really foresee potential problems and react earlier on. And I think that that's the progress that we hope to see in the future. I will say that there's a very small portion of surgeries that are more elective, where we think that's the right option at a specific time, and we don't necessarily see that as a failure, and I'm sure this came up in that discussion.
We talked about that last month, where surgery is not necessarily a failure. At very select times, it can be the best possible treatment to move that child or adult forward.
That's true, and that still is a very viable option within our armamentary of possibilities, but we do have other options right now, so if we can delay and avoid it, we try to do that.
So a question for Dr. Croker about medication, and this is a drug, two drugs we're talking about here. The patient asks cancer risk with Remicade and cancer risk with Imuran. So Dr. Croker, that's a big question, but can you summarize your thoughts on that for us?
Sure. So I think the one thing that we know that with any kind of disease or any kind of person, they can always get cancer. And so everybody has a risk of getting cancer. Nobody walks in and has a cancer-free card that they say, I'll never get cancer. And so the one thing we know that when people have Crohn's disease or inflammatory bowel disease, they actually have an increased risk of developing certain types of cancer. And some of them are probably associated with the disease itself, and some of them are associated with the fact of the medications that we give. And so with Remicade and Humira, the two kind of cancers that people worry about the most are something called lymphoma, or cancer of the lymph glands. And that's a pretty rare disease, and so probably normal people have a risk of about 2 in 10,000. And when you go on these medications, your risk goes up to about 4 or maybe even 6 in 10,000. And so I think it's rare, and if it happens to you, it's not good. But I think you have to understand that the overall risk is pretty small, and that you have to think about the risk if you don't go on those treatments, if you're going to get worse in other ways. The other cancer that you think about that we would see with these kind of therapies are skin cancer. And I don't know if they see it much in pediatrics, but we do see it in adults. But so the big thing to remember is that you actually should be protecting yourself from skin cancer. The one thing is to wear a hat, to wear sunscreen, and protect yourself from the sun. And that's something that everybody that's on immune suppression should probably be doing. In fact, everybody should probably be doing it so you reduce your risk of skin cancer. Because most of that's treatable, but at the same time, it's better to avoid it.
So there is a small risk you mentioned of these two drugs, and you use the number of 6 in 10,000. I think it's important for the audience to know that what the risk of not doing something, for instance, surgery, is probably 3,000 in 10,000 of having a serious operation. So the 6 in 10,000 risk with the drugs is quite small compared to the risk of not doing something.
And in my experience, it's often the child that's sick that wants to get better and is willing to take on that risk. But as a parent, it's hard to take on that risk for a child, and that's why it's scary. But at the same time, you got to remember that your child growing and developing and being well is actually important to them, and it's actually important for their overall success in life. And so you have to take on those risks and help them manage them, and then watch for things to make sure there's nothing going wrong, and continuing to follow up with your doctors in terms of that.
So we're getting to the half hour, and we're going to move soon to the physician part. But patients, I want you to continue putting your questions in, because this is a really important session. And I want to get to two questions, short answers. One is, what do you tell the school? So, Dr. Wine, what do you tell the school about this young child that may be having diarrhea?
So, hard to give a short answer, but first of all, we let them know. And we do this through the parents. So we provide the parents with a standard letter where we let them know that the child has a chronic condition. The amount of detail is something that's discussed with the family, and it really depends on the symptoms. So a specific point there was about access to washrooms. That's not always relevant for all children, but when that's a problem, we certainly on an individual basis will make sure that we can accommodate that and make life easier as much as possible. Yeah, important. I think that the parents deal with the doctor and the school as one group. Absolutely. And make sure the child is comfortable as possible in that environment. Yeah. The other question, this is a young child writing in, when do I, maybe not so young, when can I start making my own decisions about my disease? My parents are always telling me what to do.
Who wants to take that question? That's a good one.
I'm all over that one. I'm all over that one. I mean, this speaks very much to a large part of what we do as we do try and promote the independence of the young patient, to take control, to take responsibility, which comes with that as well. The part about my parents are always telling me what to do, that doesn't necessarily ever change. We have to be fair here, okay? You can be 35, you can be 55, your parents may still tell you what to do. But in terms of your disease and your ability to manage your own condition, that comes with time. It comes with a bit of practice. Now, early in the piece, 5, 10 years of age, parents are making the vast bulk of decisions, and they're trying to do the best thing for you as their child. As you get older, you start to have a bit more of a say in it. My practice, and I think it's probably fairly similar for everyone here on the panel, is that as we're capable to do so, we introduce the child to those decisions, and I very much maintain the focus on the child. I mean, you're the one with the disease. We have to make sure that you understand that you have a say in what's going on, and that you have an opinion that is valued. As time goes by, I expect that you're going to understand what medications you're on, what their names are, when you're supposed to take them.
So you'll quiz me as
For sure,
kid.
absolutely. Mm-hmm. You want to make decisions, you've got to show me that you're up to that level. Show me that you understand what's going on and that you're willing to take some responsibility. How often do you miss your medications? How often does mum or dad have to remind you to take them? Those things become markers of when you're ready to take over. Now, technically speaking, 17, 18, we formally transition paediatric or the patients under the paediatric service across to the adult service, because 18 is technically when you're an adult. But we know that this is a process.
Some of us never become adults.
Look, it's an option to grow up. It's inevitable to grow old. But I mean, from about probably 12, 13, certainly from 14 onwards, I'm already starting that process. I'm already asking the child to be involved with decisions and making sure that there's an understanding of what's going on. So I think it's a fluid point. Yeah. The short answer, as you asked for, sorry I didn't give you a short answer, but it's essentially when you're ready. When you're ready, when your parents are ready, and when the disease in a situation that you're able to understand it. But when that exactly is, varies for everybody.
Okay. So thank you, Dr. Carroll. That's a great answer. And I'm going to use this opportunity before we go to the physician discussions to get Dr. Croker to tell us about her IBD graduation school that's coming up in June.
So there's 2 events that are coming up, actually. So next month, our webinar is about transition from pediatrics to adults. And then on June 3rd, there's actually a night session with all of us presenting and doing an interactive session at the University Hospital about transition in the evening. So you can talk to the pediatric guys, and it'll be on our website shortly as well.
So if they want to find out about the transition school and that lecture series you're giving, where would they find that?
Our website, IBDclinic.ca.
IBDclinic.ca. You can see the website behind all of us. That website will have not only the information about the transition school that's coming up in June, but we'll also have this webinar and all previous webinars. IBD TVs will be posted on there, so you can watch these over and over again if you like. You can go through the questions and hear what the doctors here have said. And in addition, on that website, you can actually type in new questions, and over time we'll answer them in a frequently answered question section. So I'm going to end this session for the patients. Patients, I don't want you to leave, though. I want you to stay. I want you to continue to put in your questions, and we will get to them in time. But now we're going to move to another section, which is a bit more detailed on pediatric IBD, and I'm going to ask Dr. Carroll to go through a little teaching set for the physicians that are online on pediatric IBD. Dr. Carroll?
Thank you very much, Richard. Just for those who have been watching up until now, some of these slides will be very similar. But we're going to go into a little bit more depth, looking specifically at aspects of pediatric diagnosis and treatment that will apply slightly more to the physician group that may be watching. So as we have previously mentioned, and as an opportunity to reiterate, one of the big things with inflammatory bowel disease in pediatrics is recognising that it actually does happen. One of the reasons why we sometimes see children very late is because it hasn't necessarily been thought of. And that's not a fault necessarily of anybody individually, but it's the fact that it's not seen as commonly, and there is a very strong belief both amongst families and a lot of the literature in some respects that this isn't a paediatric problem. Well, as has been pointed out, it is. We know that up to about a quarter of total cases of inflammatory bowel disease are going to present within the childhood years, so less than 20 years of age. The very young children, not so much. You know, maybe 3 to 5% of all cases are presenting under the age of 10. So that does become a much more unique presentation. But it's very important that we do recognise that it happens in children. And as a result, making that diagnosis actually requires a very high index of suspicion. Basically, if you don't think of it, you may not get the diagnosis. Importantly, it does occur at any age. There are specifically ages where the risk is higher in early adolescence, through late adolescence and into early adulthood are the main peak. But we certainly have children from very, very young ages right up to 18 that will present. And the issue as well, I think, to recognise within paediatrics is, unlike a lot of what we were taught at medical school and subsequently, the presentation of inflammatory bowel disease in children can be quite different. It can be very subtle, and it can sometimes be very, very challenging to make. Even when you think pretty confidently this is inflammatory bowel disease, getting the proof can actually be very challenging, and we'll come to that a little bit further. The other aspect is that paediatrics and children, when they're presenting with chronic disease, present with a very unique set of vulnerabilities and challenges for us in terms of medical management and long-term management and prevention of complications. Again, just to touch base very quickly, I mean, Canada, as has been discussed, I'm sure, on the program before, has an extremely high rate of inflammatory bowel disease in the published literature, and whilst we continue to look at specifically why that is, we're seeing these increases in the number of people being diagnosed with disease, and certainly in children as well. And this is a paediatric study done by Eric Benchimol in Toronto on a population group, where over time, from 1994 to 2005, they very clearly saw an increase in the number of children being diagnosed each year with inflammatory bowel disease, more so Crohn's disease and ulcerative colitis. And that leads us then to this growing problem of inflammatory bowel disease within a paediatric population, and then by its very nature, the fact that these children are going to have disease for a much longer duration compared to someone who's diagnosed in their 30s or later. Some other unique aspects of the paediatric disease and what we refer to as the phenotype of disease, so the way in which the disease may present and behave, is that it would appear that for most children, the extent of disease, so how much of the intestine, how much of the bowel is affected by disease, is more extensive. And depending on how you measure it, may actually be more severe as well. So there may be more severe degree of inflammation, or that inflammation, it doesn't respond as well to therapy. When we look at management issues, we're in a very difficult situation at times, because the majority of the research that's done, the majority of testing of new drugs, trialling of new therapies and the like, and do not include a paediatric population. In fact, as we see with most things in medicine, pregnant women and children are almost ubiquitously excluded from a lot of these drug trials for clear reasons. The difficulty, though, is once we have these therapies often in practice or in having been approved for use within an adult population, we're then left with a bit of a difficulty is, can we use these same therapies in younger people? And that often doesn't have a huge evidence base to it, so we need to extrapolate information from other sources, from the adult papers that are looked at, and determine whether or not our individual situation with a specific child is commensurate to using such therapies. And again, based on the type of approval and what evidence is available for the use of certain therapies, there are some things that are not allowed to be used within paediatrics, or more commonly where we have to apply for very special access to those medications, and that can take some time, and it does restrict what the average person may be able to prescribe in the community setting. So then you end up having to really be under the care of a specialist like Paediatric IBD group, where these types of therapies are channeled through. So just to expand on some of those points a little bit, when I was at medical school, not as long ago as Dr. Fedorak, but when I was there, that one of the comments that was always made was kids, you know, when we're doing paediatric training, kids, they're not just little adults. And we make this as a sort of a joke, but the reality of it is that they have very unique set of issues. Their physiology changes and is different as they're growing, and at different periods of age, the way their body deals with disease, the way their body deals with medications can be very different. So I mentioned previously about atypical symptoms. You know, the abdominal pain, bloody diarrhea, those sorts of things that we typically expect people to present with inflammatory bowel disease may not present in a child at all. You may just have extensive lethargy, you may have unexplained anemia, you may have growth failure, as we've mentioned earlier in the program today already. It may present with depression, it may present with social isolation. Most teenage boys that I've spoken to are not willing to fess up about their bloody diarrhea and how many times they're going to the washroom. So a lot of this is not discussed. Sometimes the children don't know how to put these things into words, and so the way in which a patient may present to your office could be very, very different. And that harks back to the index of suspicion that we're required to have. Again, as I said, the more extensive disease, so when they're being investigated sometimes in the community, where in an adult setting, a limited endoscopy, so maybe a flexible sigmoidoscopy may be adequate. In children, that's generally not the case, and our kids routinely will have a scope of the upper GI tract, so an upper gastrointestinal endoscope, as well as a full colonoscopy where we get into the end of the small bowel. And that's our benchmark, basically. We don't do limited investigations. Growth failure, we've talked about a little bit as well, and this can be a major problem, and is one of the primary focuses we have as paediatricians dealing with inflammatory bowel disease. Because once you hit puberty, if you hit puberty with this sort of process that's not being controlled, potentially you don't hit puberty, but there is a window of opportunity for growth. And once that window shuts, that's it. You're left with stunted growth, or you're left with poor bone health, or the like. So there is a real importance in our therapeutic approach to monitor growth and to really maximise the nutritional and the normal growth and development for the child. And again, there's this sort of issue with other conditions. So particularly the young children, so maybe kids under 5, we think may have potentially unique disease or a very unique variant of inflammatory bowel disease that does have overlaps with certain immunological and allergic disorders. So things like immune dysfunction and potentially unique genetic conditions such as interleukin receptor deficiency. So these things that group of people may represent a very specific sub-cohort which we need to address and look at differently, and there's ongoing research in this issue and in this area. But it's not just necessarily a straightforward IBD diagnosis either. We also have slightly alternative ways of approaching investigation for a lot of our kids, and I've mentioned the upper GI scope and as well as colonoscopy. But because of the nature of growth and you know, a lot of expanding and replicating cells, we try very hard where possible to limit the exposure to ionizing radiation that we see with CT scans and standard X-rays. As a result, I'm not sure that we're more reliant, but we have a tendency amongst our own practice to be very favourable of ultrasound and as well as magnetic resonance enterography, which is, for those non-physicians in the audience, a radiation-free form of X-ray, I suppose. It uses a big magnet. In our population, we really very rarely will use contrast studies these days. There are instances certainly where they are viable and they're appropriate to use, but as a baseline investigation, we're not doing contrast studies. We're not doing contrast enemas to assess these things. Child presents with rectal bleeding, the likelihood is they don't have rectal cancer. We don't see that in our population, so a contrast enema is not going to be your first choice of investigation. Again, CT enterography, we would generally prefer to do an MR enterography unless there was a critical, the child was very unwell, there was a suspicion of an abscess or something more urgent. And as I mentioned, limited endoscopic examination, at least as an initial investigation, is generally not recommended. Some of these issues with alternative approaches to therapy we have also gone through in some detail already, minimising the steroid exposure because of the impacts on growth and bone health, optimising nutrition, which includes not just the mention previously of exclusive enteral therapy as a specific treatment, but also of the supplementation of nutrition so that growth and development is maximised. And this requires close dietetic monitoring. So again, in our specialist clinics, we have a paediatric dietitian who is always there with us and helps us manage these kids in a very close relationship. Furthermore, as the duration of disease is longer and kids being diagnosed earlier in their life, we do have to give very careful consideration to the long-term impacts of a lot of our therapies, as well as the long-term impacts of disease. And what that may mean, particularly in instances where we don't have evidence for some of the outcomes of the newer drugs, particularly at 30 or 40 years down the track. We don't know what they're going to, what impacts they may have or what complications we may be facing. Monitoring of bone health is one that is very important, again, to maximise bone density and growth and development before that window closes. And issues with surgery, I think, have been adequately addressed in other sessions. Importantly, the psychological and emotional support of kids, I think, is something that really has to be focused upon, and it cannot be separated from the general management of inflammatory bowel disease in paediatrics. And in fact, I'm fairly confident it's not managed, it's separated in the adult population too, but there are some unique issues here. We do have to think about this process of transitioning them to an adult service, and a service that is, by its population defined, a service that does do things slightly differently than what our clinics may do. We have to think about the long-term issues of cancer surveillance and when to start that, even in young children. Importantly, issues like self-esteem, emotional maturity, sexual identification, and the development of peer relations can be a major issue when you're struggling with a chronic disease, particularly if that chronic disease means you're rushing off to the bathroom every 5 seconds. So that can be a really big issue. This extends then subsequently to issues of fertility in young adults, and not just in terms of their sexual identification and self-esteem, but also in terms of medication usage and the potential issues surrounding that. And of course, employment. If you've missed a lot of school, if you're sick and you can't get to university, these things have an impact on what you see yourself doing in later life, and potentially what opportunities may in fact be available to you. So these are things we need to be thinking about in order to support that young person getting through an already difficult period of time in adolescence in order to reach their their potential goals and their potential the best quality of life that they could have achieved otherwise. So just to finish, I think one of the things, again, with the focus on paediatric care here, is that parents and children really feel like they've lost control of their own bodies, they've lost control of their own lives. And this is something we try as much as possible to return to the child. We try to make childhood fun again. You know, having these sorts of diseases can rob some people of their childhood and of a lot of a period of innocence potentially that may have otherwise existed. Ensuring growth and development is critical, as we've discussed, and maintaining that quality of life, because this is a long-term disease and these kids are already suffering at very young ages. Most importantly, we have to look at the child within the context of their environment. So we work very closely with the family as a unit, extended families often, to make sure that we're trying to address and tailor therapy to the environment that child exists in.
Yeah, thank you, Matt. That's you've really covered a really key area, that this management of IBD, particularly in this age group, is a multidisciplinary, multidimensional fact. You need to look at lots of parts of the holistic part of the patient. So that's really important. I wanted to remind the audience out there that this session today is sponsored by an unrestricted educational grant from AbbVie Canada, but that they have no input into any of the topics or the discussion here today. But let's go directly to the questions. We'll start with this one from a general practitioner here in Alberta. I have a young boy, age 10, who has chronic diarrhea, abdominal pain, fissures, failure to grow. I'm really concerned he has Crohn's disease. However, I sent him to a specialist who said all the tests were normal. What else should I do to investigate? So, Dr. Wine, what would you do with that? This referral is now coming again to you. What are you going to do?
Well, sometimes the referral does have to come again to us, because I think that we're always open to reassessing, and we can comment on what we know. But I think there are two major points here. First of all, upper endoscopy and ileocolonoscopy are not going to diagnose all cases of IBD, and there certainly are, of course, Crohn's disease is what comes to mind, cases that are beyond the reach of the standard endoscopy. And we do have available to us tools. So imaging, of course, is one of the tools, and we would ensure that this child has had additional imaging. So
that imaging might be what?
MR interrography would probably be the imaging of choice.
So that non-radiation X-ray that Dr. Carroll talked about.
Which can usually be done electively, which is why we prefer that. And then we have other forms of endoscopy, either capsule endoscopy or double balloon
Why don't you tell the audience about capsule endoscopy?
I will.
Do we have that for pediatrics?
We do, and we actually use it quite often in exactly cases like that. So capsule endoscopy is a camera that an individual can swallow, or since it's quite large, in many cases, if it's a child, it has to be inserted under anesthesia using an endoscope. And what it does is transmit frequent photographs taken within the intestine to a receiver that the patient will carry over a few hours. And then we can go over the images that are retrieved and see what's happening on the inside. And for cases like this, where the index of suspicion is still quite high, that could be a very useful tool to image the parts of the bowel that are not otherwise available.
So that mid-small bowel that's not seen by the gastroscopy or the colonoscopy. Yeah. So in this case, you'd ask that general practitioner to send you the referral, and you can do that test for them tomorrow?
Yeah, so we do. I have to check my calendar about tomorrow, but absolutely, I think that, that the second point is that we always have to reassess, and there are cases where very early presentation of disease might not be picked up yet, and if there is a high index of suspicion, then we're happy to challenge it, and we have repeated endoscopies a couple of years later and found things that weren't there before.
Right.
So
it's disease in evolution. Sometimes you don't see it early on, and I think that GP who's writing to us, I think that's the important point. We'd all be happy to see that patient again and try and help you out. Another question here on vaccination. I don't know which one of you want to take this. Maybe Dr. Coker, you might start a little bit from the adult side, and we'll move back to the earlier vaccinations. But the question is, can you discuss vaccination status and requirements and IBD meds?
Okay.
Big question. So why don't we focus it on what vaccinations are needed?
So I guess what we always look for in terms of is that there's a vaccination schedule set out by Health Canada or by the Alberta government, and there's certain vaccines that are killed and there's certain vaccines that are live. And so killed vaccines anybody should get, and then there's live vaccines which, depending on the types of medicines you're on, you shouldn't get at that time. So when you're immune suppressed, if you get a live vaccine, you could get the real disease, but with a killed vaccine, that same risk doesn't exist. And so the couple things that we look for in adults is that to make sure that you actually have been vaccinated for hepatitis B. And so there's one of the things where people actually can get reactivation when they get treated with certain medications. And then there's making sure that you don't have active TB, which isn't a vaccination, but it's actually a skin test we would do before giving you biologics. In terms of the other vaccinations, is that making sure you're up to date with those, especially those live vaccines before starting on medications, means that you actually can
before starting on the immunosuppressive medications, right.
Means that you can actually be protected from those risks, because I think when you're immune suppressed, your ability to fight those infections are less. And if you got a primary, say, chickenpox infection while you're immune suppressed, you can actually be even fatal. And so we actually worry about that quite a bit.
So we'll start get the vaccinations all up to date before you start the immunosuppression, if at all possible. And Dr. Carroll, what about in the pediatric group? The young patients, do you have them normally get all their vaccinations on a routine schedule?
So the same rules apply as what Dr. Croker mentioned, that there are some exceptions depending on where they are age-wise, but also in terms of therapy. So we have to look at the age of the child and firstly check, have they had the vaccinations according to the schedule? And preferably we like to get documented evidence of that, because, frequently people will say, yes, I'm up to date with my vaccinations, but what that actually means can be varied. So we do like to get documentation of what vaccinations have been given, and in some instances we will do serology to look for how effective that vaccination has been. In instances like chickenpox, for kids who have had exposure to the disease, so confirmed exposure, confirmed case of chickenpox, then that does give them a natural immunity to it. And so we wouldn't go and pursue chickenpox vaccination in that instance had they not yet had it.
And to answer one of the questions that just popped up, would you ever accelerate the vaccination schedule of the child in order to give them these medications we're talking about?
Yes, we do that. Particularly when you are on immunosuppressant medications, the risk of getting some of these infections can potentially be increased. So we do try to have vaccinations in place to give as much protection as we can to our young patients from these naturally acquired or potentially naturally acquired infections. We do have protocols for accelerated vaccination, and this is the same sort of thing that we do with our in other areas of medicine with transplant protocols and things, where we want to try and ensure that children are accelerated. So there is good evidence for it, there are protocols for it. They're specific depending on the age of the child and what vaccinations are involved. So that generally requires an individualized approach.
Right, and so the family doctor would work with you on getting that approach organized. One question, I think the last question we have time for in today's session is maybe for Dr. Wine. Do kids also need colon cancer screening once they've had colitis for more than 10 years? And that may come from, we talked about needing to surveillance people with ulcerative pancolitis. What about children? Do you have to do that as well?
So colon cancer in children is extremely rare, even in those that have high risk factors. I think that for the physicians among you, the one exception for that is co-occurrence of primary sclerosing cholangitis, PSC, which really accelerates the risk in a very dramatic way. In that population, we will start screening, not waiting for the 10 years, but almost immediately after the diagnosis is made on an annual basis. But the rule of wait 10 years and then start scoping every year for ulcerative colitis generally has applied for children. I think that as new data is emerging and really raising questions in the adult world as well about this schedule, we are certainly following the very recent literature on that. Generally, we do follow that rule, and most of our children will undergo a colonoscopy after 10 years from diagnosis of ulcerative colitis. But I think that that's something that is likely to change over the next few years.
It may be changing. So for the family practitioners out there, that's been our standard, but there is new literature that we may not need to screen quite as frequently. Absolutely. And do that surveillance quite as frequently. So I wanted to bring this session to a close. I wanted to thank all the audience out there for the great questions, and there are many more, and we'll get to them in our frequently answered questions on the website at some point in time. I wanted to thank Dr. Matt Carroll from the University of Alberta, pediatric gastroenterologist.
Thank you.
Dr. Etan Wine, also from the University of Alberta, pediatric gastroenterologist. And of course, the lovely Dr. Karen Croker, who's in the middle here, an adult gastroenterologist who's been with us now for all of our sessions. So, ladies and gentlemen, thank you for your attention. Just to remind you that this IBD TV session is on our website, again, www.ibdclinic.ca. And we look forward to seeing you again next month at the same time, when we'll be talking about transition care. So taking these pediatric patients and moving them into the adult world. What does that look like? What do we need to do about that? And are there special care that we need to take? So thank you very much for your attention today, and we look forward to seeing you next week.